Hi, my name is Tim Bale and I'm co-director of the Milan Institute at Queen Mary University of London. Welcome to another in our series of videos on COVID-19 and the coronavirus crisis. Today we're going to be hearing from my colleague, Dr. Andreas Papamichail, who is going to be talking about the impact of COVID-19 on societies which are suffering violent conflict and therefore whose health systems are severely weakened. If you enjoy this video, please do share it and please do come back for more.
Hello, my name is Andreas Papamichail and I'm a lecturer in Global Health and International Relations at Queen Mary University of London, where I research and teach in the global politics of health. Among my research interests is examining how health security practices and conflict intersect. And in this video, I want to bring your attention to three interrelationships between the coronavirus pandemic and conflict. Namely, how weakened health systems will hinder the response to the virus, the increased risk faced by vulnerable populations, and finally, how conflict dynamics can become wrapped up in the pandemic response. Prolonged periods of conflict and insecurity can have a range of effects on the adequate functioning of health systems. These include a breaking down of the overall governance of the health system, a disintegration of health information system and surveillance capacities, medical supply shortages, disruption of treatment for chronic illnesses, destruction of health facilities, and health workforce shortages as healthcare workers either fall victim to violence or are forced to flee because of it. All of these effects will hinder the ability to adequately respond, prevent the rapid spread of COVID-19, and limit the ability to treat those who are infected, while also increasing the vulnerability of those with underlying health conditions. A key part of the coronavirus response globally is going to be the ability to test, isolate, and contact trace patients, activities that will face specific difficulties in conflict-affected areas, where obtaining reliable data and reaching affected populations is complicated by insecurity. Meanwhile, the ability to treat the most severely affected coronavirus patients will be extremely limited when intensive care unit beds and ventilators are in short supply. Moreover, as my colleague Professor Sophie Harman has pointed to, we also need to keep a focus on what other health issues are neglected when attention switches to tackling the coronavirus. For example, sexual and reproductive health. And this is no different in conflict-affected areas, and indeed neglect of other issues will be even more pronounced when health systems are crippled and resources are sparse or wrapped up in the dynamics of conflict and the political economy of conflict. And these are the reasons why we should be concerned about what will happen if and when coronavirus takes hold in places like Syria, Yemen, or the Gaza Strip, among others. The conflict in Syria, for example, has severely weakened the health system in many regions of the country. And according to the WHO, half of Syrian public hospitals are either only partially functioning or fully destroyed as a result of the war. In Idlib and its surrounding region, 85 attacks on health facilities occurred in 2019 alone, severely damaging health infrastructure, and nearly a decade of war has precipitated the exodus of a large portion of the health workforce in the country. In fact, according to a recent UN report, as many as 70% of the Syrian health workforce has been forced to flee the country. And thus, a recent report by researchers at the London School of Economics suggests that the absolute maximum capacity threshold for COVID-19 patients in Syria is 6,500 patients. But this threshold is geographically skewed towards government-held areas and leaves many other areas particularly vulnerable. Save the Children have noted that there are only 153 ventilators and 148 ICU beds in the entire northwest of the country. And this brings me on to the second overall point I want to make in the video, which is around the increased risk faced by vulnerable populations. Now, here in the UK, we're already seeing all around us how the coronavirus exposes inequality in society along class, gender, race, and other lines. As abilities to work from home or not, having the space to maintain physical distance, caring responsibilities, socially determined susceptibility to underlying illnesses, and treatment within the health system, among other things, impact the way that the pandemic is experienced by different people. In conflict-affected areas, inequalities are compounded as social relations and support networks are disrupted. People are displaced from their homes, access to health services is hindered, and people lose their sources of income. All of these disruptions put people at greater risk of exposure to COVID-19 or render them less able to deal with the effects of the virus. And as many have pointed out, lockdown and physical distancing edicts are only possible in some contexts and may be impossible or at least severely complicated in situations where insecurity is as much as a worry as the disease itself. Of course, there are massive differences in how different conflict-affected populations will experience the pandemic. For example, the refugee or internally displaced person living in a camp will experience the pandemic very differently to the refugee or IDP who lives in an urban environment. However, what is clear is that the conflict can and does exacerbate inequalities that the coronavirus is laying bare worldwide. And the final point I want to make is that we should not see health and healthcare as somehow exogenous from conflict. Instead, we should remain attuned to how conflict dynamics in healthcare become interrelated and mutually sustaining. This interrelationship has many potential facets. Disease and surveillance response efforts may become embroiled in conflict and viewed with suspicion and distrust when administered by security actors. Conversely, government-imposed restrictions on mobile and internet communications, justified for security purposes, can also prevent accurate data gathering and sharing and the spreading of clear public health messaging. Omar Douachi and his colleagues argue that we've seen a change in therapeutic geographies of healthcare systems in Iraq and Syria, for example, as boundaries between civilian and military broke down and healthcare became part of the tactics of war. In Iraq, the effect of this enmeshing of war and healthcare has been widespread distrust of public institutions. And this may explain why, in the current outbreak, some families are refusing to comply with quarantine orders, not least because security forces are the ones enforcing lockdown and quarantine rules. Another example where conflict dynamics in health response intersect comes from the Democratic Republic of the Congo, where the unfortunately still ongoing Ebola outbreak has at various points been complicated by ongoing fighting in the east of the country, mistrust of the health agencies seeking to stem the outbreak, and concern that the response was being used to interfere with the DRC's national elections. Similar difficulties could arise in responding to the coronavirus, not just in the DRC, but elsewhere. We should also remember to situate these conflicts in wider perspective and consider how regional or global dynamics are fomenting or helping to sustain violence and insecurity, and by extension the health implications of those conflicts. For example, analyses of the impact of COVID-19 on refugees and IDPs should also really take into account the border controls and policing measures that have exposed people on the move to further risk by containing them in unsafe camps or by preventing them from seeking medical care due to fears of arrest and deportation, as disease control and border control become intertwined. Likewise, the health consequences of conflict and the potential impact of coronavirus in Yemen, Gaza, and the other places I've mentioned in this video should not be detached from analyses of the wider dynamics that have made them vulnerable to the pandemic in the first place. So, by way of conclusion, ongoing and recent histories of violent conflict heighten the risks associated with the coronavirus pandemic in a range of ways. And this requires us to pay attention to how weakened or destroyed health systems might cope with the outbreak, how the consequences of the pandemic will manifest among different populations affected by violence, and finally how the pandemic might intersect with conflict dynamics or be used to justify tightening of security measures. And that brings me to the end of the video, and I'd really like to thank the Mile End Institute for hosting me, and thank you for watching.